Thank you. I'm really pleased to be here today to share the progress on Priority 1, Strategy 2, Foster Leadership Through Improved Performance Management and Succession Planning, which falls under Priority 1, Organizational Wellbeing. I'm Terry Smith, Manager of Quality, Practice and Relations, and the lead for a strategic initiative. Joining me today from our working group is Julie Patno-Bouffard, the Manager of Oral Health, who's my co-presenter, along with Shannon Mantha, the Executive Director of Clinical Services and our Chief Nursing Officer. And in addition, our working group includes 6 other members from across various health unit programs who have contributed to this work. This strategy grew out of an earlier manager-led effort to improve performance management. When it became a strategic priority, we were able to build on that foundation and move the work forward. Next slide. Before we dive into progress, I want to frame a few key concepts. Oh, sorry. Could you go to the next one? The next. So the first is competency profiles, which are documents that outline the knowledge, skills, and behaviors needed for success in a role. They guide development, recruitment, performance evaluation, and succession planning. We align them with the Ontario Public Health Standards and core competencies for public health practice. The second is performance management, which is an ongoing process that includes setting clear goals, providing feedback, supporting growth, and recognizing achievements. Strengthening this system helps our staff to succeed and drives continuous improvement. And finally, succession planning, which is one of the strategies that helps us prepare our organization for the future by developing leadership capacity and planning for key role transitions. There are 2 streams, managing risk for critical roles and developing future leaders. Our focus is on the second, developing future leaders. I'll now turn things over to my colleague, Julie, who will walk us through our progress to date.
Thanks, Terry.
Next slide.
So here's where we started. As Terry mentioned, we wanted to build on what had already been done, not start from scratch. We also knew there had been other leadership efforts in the past to improve performance management, so we made sure to include that work as well. From there, we reviewed best practices and evidence related to both performance management and succession planning. We looked at what's working, what's challenging, and where the gaps are in our current process. We also engaged both our management and executive teams for their perspectives. And finally, we pulled it all together into a logic model that helped us define our goals, outcomes, and what resources or factors we need to move forward effectively. As we looked at the research on succession planning, we noticed 2 very different but equally important approaches. The first is risk management. The second is where our team is focused, leadership development, identifying frontline staff who are both high performing and high potential, and supporting them to take on stretch opportunities and development. We also recommended updating our competency profiles to reflect what's needed today and in the future. And for performance management, we decided to pilot a system first, test it, learn from it, and then roll it out more broadly in years 1 and 2 with an evaluation afterward to make sure it's meeting our goals. Here's where we are in our plan. Our competency profiles are about 82% complete, 53 out of 57 done, so we're almost there. We selected Pulse 360 for our pilot performance management tool with launch in mid-November. We're putting together a manager toolkit, something practical and useful, containing coaching resources, tips for having difficult conversations, and tools to help managers support their staff more effectively. And finally, as part of our succession-focused staff development, we'll be doing a workforce capacity assessment. Next slide, please.
I think we're good, Shelley.
No, we're good?
Yeah.
So now we'll talk about the tool we'll be using. Pulse 360 has 360 feedback surveys, which are web-based and completely anonymous. These surveys gather feedback from peers, staff, and even community partners, so you get a full picture of how someone is doing. It's a validated best practice tool that uses Likert scales, and it's very efficient. Once staff get their feedback results, they'll have access to targeted coaching and education modules. There are over 100 to choose from. They're all online, easy to access, and really practical. The system lets us see trends across our organization so we can get a sense of how our teams are doing overall. Reports are also based on healthcare benchmarks, so we can see how we compare to similar agencies. And with that, I'll turn it over to Terry to share more about our anticipated outcomes.
Thanks, Julie. Next slide. So here's what we're expecting to achieve with our planned initiatives. We're looking to foster growth-focused conversations, and we expect to shift from biannual transactional reviews to a more meaningful trust-building conversation. By using the coaching approach, we'll support staff development through regular, reflective dialogue that encourages progress and engagement. Secondly, supporting continuous learning. We expect to embed learning into everyday work. We are building systems where individuals reflect, share insights, and apply new knowledge in real time. This will help us to stay responsive and continuously improve how we serve our communities. And finally, advancing effective public health practice. It isn't just about improving our internal processes. We expect that by strengthening individual communication and collaboration skills, we'll be better equipped to engage our vulnerable populations, build strong partnerships, and work more effectively to deliver coordinated, impactful public health services. These are the outcomes we're aiming for. Evaluation will be key to understanding our impact and guiding improvements. Next slide. Thank you, and we're happy to take any questions you may have.
Lynn, more of a comment. I absolutely love the conversation with employees, because I'm always shocked when they talk about doing a performance appraisal and people are surprised what their results are. So having that, like, everyone in your organization should know how they're doing it any given day. They should not be. So I really, really think that is absolutely amazing that the organization's, is moving in that direction. There's a lot of the survey work and those kinds of things, but is there any ability or is there any thought of having actually a live coach for like, not when they're on a PIP or anything like that, but someone like, every coach needs a coach. So I know you might be getting it from a supervisor or maybe a contemporary, I'm not sure, but do they have access to some kind of live coaching?
So as supervisors, part of the program is for them to coach us in the way that we work with our staff. So that is part of the program that we have.
So we don't have like a certified executive coach that could, because even the supervisors should have a coach, right?
Yeah, so I can jump in. So through Pulse 360, we can access that. Now it's not part of what we're currently doing, but there will be an option. So I think in the event that we identify that over time, we've just started rolling this out. So we're all kind of getting used to the process and the tool. I think if we identify that add-on piece of coaching is helpful, we will use it. Historically, we have purchased coaching for times when it's needed, where we felt like our internal skill set didn't match the need. So we've done that in the past, but yeah.
Yes, we've done that in the past on an individual level, but also at the management, like offering coaching sessions to the management as a whole. Was it June 2024? We had all of management coach, trained in a coaching approach.
Right. Right.
So it's kind of part of the ongoing investment as well in management.
Because there's lots of evidence to show that kind of environment, that kind of culture actually increases productivity immensely. I think it's changed, totally shifts the focus, because we tend to do more crisis intervention with PIPs and all that, and by then it's almost too late. But by having this, embracing the coaching culture it's outstanding. So congratulations.
Brings enjoyment to the workplace.
Not at the board level, but certainly in the work.
We need coaching. Well, thank you very much. Any other questions online? No, we're good. Thank you very much. We'll go to item number 2, priority 2, strategy 4, cultivating our role within the system level for efforts to reduce poverty and homelessness. Mr. Chris Bowes and Aaron Reese.
Great, thanks, Rick. So I'm Chris Bowes. I'm the Executive Director of Organizational Effectiveness. I think last time I was at the board was probably the last strat plan update we did in Parry Sound, so it's great to be back. And then Aaron Reese, the Health Motion Specialist, is my co-lead on Priority 2 Strategy 4. So as Rick said, our focus is cultivating our role within system-level efforts to reduce poverty and homelessness. And we have a working group of 8 different members from different programs across the organization. It includes people from organizational effectiveness, clinical services, and community services. And there's been a lot of value in having different perspectives, and we've helped each other see what the priorities are, where they fit within our organization and in our own programs and organization as a whole. So that's been great. You can jump to the next slide. And just kind of highlighting the situation that we are looking at now. So we've heard these key points through consultations we did leading up to the development of our strategic plan. And then we clarified or reinforced further as a result of the situational assessments we've undertaken this year to better understand poverty and homelessness across our district. So homelessness, poverty, and food insecurity are persistent and worsening public health challenges that have significant impacts for individuals and communities. People experiencing low income or homelessness face substantial barriers to accessing healthcare and social services, often resulting in increased emergency department use and poorer health outcomes. Despite growing need, responses remain primarily focused on crisis management rather than prevention. So, and public health's role in addressing these issues needs to be more clearly defined sometimes. Finally, one of the key things that we've talked about as well is that those with lived or living experience are rarely engaged meaningfully in shaping the programs intended to support them. And this is a gap that we need to start addressing. And so what is the why of what we're doing? You can jump to the next slide, Shelley. And why are we doing this? So income and housing are highly influential social determinants of health. They shape the conditions in which people are born, grow, live, work, play, and age, and significantly impact health outcomes. Homelessness and poverty are public health issues because they are systemic, widespread, and preventable contributors to poor health. They increase vulnerability of disadvantaged populations on many levels and create barriers to good health. These disparities are systematically linked to social and economic disadvantage. So why are we doing this? Why is this part of a strat plan? I know that social determinants of health, health equity are public health work overall, and public health as a system has addressed these issues for a long time, well before our new strat plan. But what we're doing with our strat plan though now is it was approached often through a fragmented or siloed approach. And the difference now is that we're approaching this as an organizational wide approach, one that is better aligning the work the programs do, learning from each other's successes, and also developing shared approaches to more complex issues and problems. There.
Yeah, thank you. Okay, next slide. So here's where we're at in the planning process. We've been working to understand what key data indicators that relate to poverty and homelessness, things we should be considering, and what data related to those indicators that we have locally, as well as where there are gaps to inform future data collection projects. We've prioritized developing a clear understanding of where income and housing sit within the Ontario Public Health Standards to wrap our heads around the scope of public health work on these issues. We've been networking with community partners to gain an understanding of what's happening in the community already, understanding their perspectives, what their responses to poverty and homelessness are, and identifying opportunities to collaborate. Lastly, we've prioritized ensuring our group is clear on what our responses to poverty and homelessness are internally. So our group has undertaken a mapping exercise to identify activities the health unit is implementing that fits within this work, and which will help us identify where efforts are concentrated and where there are gaps. So this information has helped us identify the key components of our logic model, and we're making good progress toward planning for meaningful action. Next slide. So here I'm sharing a bit more detail about how we are planning to group our activities. Initially, our group was grappling with the language of our strategy that was limited to just
reducing poverty and homelessness. And we were trying to understand how to best fit activities that in theory would align with this goal, but don't necessarily directly reduce poverty and homelessness. So we've arrived at this framework that includes the language of preventing, reducing, and responding to poverty and homelessness to align with the spectrum that we use in public health of upstream, midstream, and downstream approaches to the work. So each area is equally important, but we do want to try to swing the volume of resources being directed to what would be considered responding to poverty and homelessness more toward the prevention side, so that we're focusing more upstream on preventing these issues in the first place. Next slide. And in addition, we want to keep in mind that housing, income, and food are deeply interconnected social determinants of health that influence an individual's ability to live a healthy life. When any one of these is compromised, it can create a ripple effect that worsens health outcomes. Together, they form a foundation for health, and addressing them collectively is essential for public health strategies. We want to break down silos of work happening in these areas to ensure a comprehensive approach, while acknowledging that activities in each of these areas do require distinct interventions as well. Next slide. So in terms of next steps, over the next 6 weeks, we're working on finalizing our action plan for 2026-2027 based on the results of our situational assessment. We're having lots of discussions with the other 3 strategy groups under the health equity priority, given how interconnected our work is. We continue to strengthen partnerships with community organizations. We know we can't do this work alone, and we aren't necessarily leading this work in the community, but we also want to make sure that we're not duplicating efforts, that we're meeting community need, that we're seeking out opportunities to collaborate while staying focused again on that population health approach as much as possible. We want to ensure staff across the health unit understand where their work fits within our strategy to foster a high level of engagement with this work. And in the meantime, we don't want the planning process to stall work that we know can go ahead. So we are moving forward with some activities that we know align with our strategy. And one specific example is that we have expanded our annual work on food affordability to include a more robust housing element. So this reporting will be available in January of 2026, and I'll be back visiting you at that Board of Health meeting with a more comprehensive update on that report. So that's really exciting, and it definitely meets a gap in the community that we haven't filled before. So that's it. We'd be happy to take any questions you may have.
Any questions? Jamie Larry?
I mean, it's good work. It's just there's so many players in the space.
Yes.
I don't know how you navigate all of these parameters, because they're, you know, there's always talk in the community about being siloed, and then, you know, the city has their own committee, and, you know, the OHT has a committee, and like, so how do you go about sorting out the partners, and how do you navigate all that stuff?
Yeah, it's definitely been a challenge. And like you said, there's many partners to connect with, and it's been challenging to understand exactly where all the pieces fit and who's doing what. I think the gap that we are definitely filling is kind of being more zoomed out on that population level and working more on the prevention side of things, and connecting some of the higher level work that we do to homelessness and poverty prevention. So another really key piece that often gets missed in the community is advocacy and knowledge translation. So often we're sitting on really great data, but we're not doing enough with it. So we really feel that that's a role that we can contribute at the community level.
Yeah, and that's something else we've done as well. We've connected with community partners about data information they've been collecting, and making sure that we're getting a really wide picture of this, and talking to partners and getting their perspectives as well. And that was part of our situational assessment, was, you know, connecting with partners who are doing this work and seeing what they're doing in the community, where our work overlaps or complements each other as well. But yeah, you're right. It's
Follow up on that. Like, has anybody ever mapped any of this out? Like, looked at each organization and what they provide, and it's almost like leaning out to sort of identify exactly where those things are, and like it's a real mosaic of services that are sort of, you know, blobby, and but to map this out based on, you know, organization, to clearly identify where these zones are, where the overlap is. I mean, it just seems to me that there's, because of that, nobody's really sat down that I know of to figure out which organization delivers what, and how. So it's, and I don't know, that's part of your assessment or if anybody's ever done that assessment, but to me, that's a key sort of step to figure out where all these players, because there's talk of how different organizations are trying to do their work, but then it benefits another organization with needles, for example. They collect them here and they turn them in here and they get something there's all these, I mean, there may be urban myths or rumors, but I just really don't know. I mean, you have your work cut out for you, because it is just such a hot mess when it comes to all the services, and everybody's got great intentions. It's just, I just see that there's just so much, of unknown to navigate that whole system.
Well, and even what you're getting at is that would be a great suggestion maybe for something to consider in future as a community project. We're doing that internally, and you'd be surprised how much we do that, programs do that, see within the spectrum of kind of that preventing, reducing, responding. And that visually will help us understand where efforts are concentrated, and even in, it's more evenly balanced, I think, internally for us in terms of that spectrum. But what we can identify at the community level is efforts are definitely, and government funding is definitely more concentrated at that emergency response crisis level, because out of necessity, right? So it's like we need to be drawing more attention to what needs to happen at the prevention level and connecting some of these higher level policy issues with the downstream impacts of what the fallout is if we don't have, for example, strong public policy on housing, income security, food security. Yeah, it's very complex and it's been challenging for sure. And one piece we've worked really hard on is just getting our group on the same page, right? With staff from different programs and trying to get a foundation of knowledge of these key issues, and making sure that, collectively we have a good understanding of what's happening in the community, what our role is, and how we need to move forward in a way that feels right, based on capacity too.
Thank you very much for your presentation. That's awesome. Next one, priority 3, strategy 2, raise awareness about the needs addressed by the health unit. Kylie Wardell, she is online, I believe. Hi, Kylie.
Hello, greetings everyone. Thank you for allowing me to be part of your agenda for this evening. As you now know, my name is Kylie Wardell. I wear a couple hats on the Health Unit Communications team, currently acting as the Public Relations Specialist, and I am pleased to be a co-lead with support from Alex McDermott and Louise Gagne for Priority 3 Strategy 2, which is raising awareness of the needs addressed by the Health Unit. So from a communications and a research perspective, the title of our strategy on its own is very broad. And so one of the first tasks we were met with was narrowing our scope. We reviewed the summary report, which described the outcomes of the data the health unit had collected from interest holders when they were building the overall strategic plan. And we were challenged trying to define who exactly our target audience needed to be. What we wanted was something that would be manageable within our capacity and also create the most value and impact for the health unit. Next slide, please, Shelley. So it wasn't until we had more context that we were able to see where the greatest need for this awareness was. And some of that context arose from discussions around the board table. We talked with our Executive Director of Community Services and one of our NOW work group members who liaises with municipalities as part of her role, and it became clear that there was room for, and an important need for, improvement in the way we communicate with municipalities in the Parry Sound and Nipissing districts. For the context of this project and presentation, the term municipalities encompasses staff, management, executive directors, chief administration officers, mayors, reeves, and all elected members of council for municipalities, townships, and villages across the health unit service area. While we recognize the need for the health unit to strengthen communication and relationships with Indigenous communities, we know these communities are already a priority area for other strategic plan work groups and our new Indigenous Engagement and Development Program. As such, the focus of our strategy is the 31 municipalities in our area. Municipalities are an important audience of focus for a number of reasons. First, their constituents or members of the community are also the population public health serves. Second, we both have responsibilities to promote and support community well-being and safety, including planning and responding to emergencies. And last, they cost share public health with the Ministry of Health. To inform our work, we will also be tapping into health unit staff, managers, and executive directors who have some form of engagement with municipalities. As direct communicators, we hope that they too will be able to benefit from our strategy implementation. Next slide, please, Shelley. When we think about the work municipalities do for our population, we can see that a great deal of it has a direct link to public health. The Association of Municipalities of Ontario goes so far as to say municipal work is public health. Next slide. In fact, according to the same association, about 90% of municipal operational expenditures contribute directly or indirectly to social determinants of health. Municipalities are a source of co-funding for the health unit. We can start to see how the health unit municipality relationships are a natural fit for this strategy and an important area for strategic prioritization. Next slide. So, to raise municipalities' awareness of the needs that we address, what we are working towards is a communication strategy. Our ideal end state with this communication strategy is that municipalities will see common interests and goals with the health unit, understand how the work we are doing aligns with the needs of their constituents, and can use this understanding to advocate to governments and garner support for public health projects that serve our shared population. In addition, we hope this communication strategy can help to foster mutually beneficial relationships, mutual understanding of operations, and lead to better collaboration to support our populations in times of emergency, crises, or distress. Next slide. So I've talked a little bit already about how we determined our scope and our target population. We took a broad, vague idea and narrowed it down to something meaningful and practical. Since then, we have started working with a consulting group, a Rising Collective, who will be conducting focus groups with municipalities and health unit staff and leaders who communicate with municipalities. Our first internal focus group took place yesterday, and more will be taking place in the first week of December. A Rising Collective will compile, theme, analyze, and summarize the discussions, and use that to create a report that provides an executive summary, an overview of the process, a summary of engagement themes and findings, and recommendations for next steps. What we do and do not obtain from the summary report will inform an in-house environmental scan to understand our current communication patterns with municipalities, and a literature review to understand best practices. With a strong data collection plan in place to assess our needs, we will be able to establish our SMART objectives and make recommendations that will help us achieve our desired outcomes and outputs. We anticipate having a draft communication strategy in place for spring 2026. It will be presented to our target audience for their feedback before we proceed to the planning and implementation stages. Next slide. That concludes my presentation. I will now open the floor to questions.
I got one, right?
Okay, thank you, Kylie. Tim?
Just a question. We have, in our area of responsibility, we have multiple unorganized townships. Have they fallen through the cracks, or how do you deal with an unorganized township that has no municipal group per se? And generally, the unorganized township also have covered some of the mandate of food insecurity, poverty, because they're isolated individuals that are living out in the bush. And I'm just wondering, has that been taken into account? Because there are multiple.
Mm-hmm. Louise, do you care to speak to that?
That's a great question, Tim. At this point in time, they haven't been included in this assessment. But that's not to say that we can't include them as we move along into the strategy. The timing of which we're doing the focus groups is pretty short. And as it is, we're starting to see some people are not available in December. So it's certainly something that we can look at how we can better reach them in the new year.
I understand based on pure population, you want to hit the larger population groups. I totally get that. But like I said, I know there's multiple unorganized townships that could probably really use the help that you guys are targeting as food insecurity, homeless, housing, all that kind of stuff. I just wanted to toss it out there.
Oh, I appreciate you bringing that forward.
Identify that.
Well, it's great work too. And we've talked about this before about getting out there to the public and letting them know exactly what the health unit is doing. And this is the one way of doing it, and especially with the municipalities, getting them involved. This is absolutely awesome. I think it's great. Any other questions? No. Online? Again, thank you very much. This has been a great presentation, and thank you so much.
Thank you.
Thank you, everyone.
Thank you.